All right, and welcome back to episode 22 of Modern Prescription. My name is Dr. Deepak Dugar.
And I'm Dr. Jeff Toll.
And today we're talking about some cool stuff.
Yeah.
Talking about psychedelics, talking about some mushrooms.
Yeah.
Talking about...
The country's really getting excited here.
Yeah.
Party time.
There's a lot of stuff going on. We've got a good energy and a lot of weird energy with COVID. Talk about COVID and how it's back. Stronger
COVID's
than ever.
Back. Vaccine may be close.
Yeah.
Winter's coming.
Winter is literally coming. That is a great Game of Thrones drop there. I like that.
There you go.
And we have our guest of the day, Dr. David Lazar.
We're going to learn about the eyeball.
About
the eyeball and seeing.
Eyeball doctor. A lot of people don't know much about the eyeball, so this will be a good one to learn a little bit.
They're complicated. They're gross.
They're gross.
And we found someone who shoots them with lasers. So let's get him on here.
Yeah, and we're going to talk about what the favorite and best eye color is.
That would be my eye color.
Stay tuned. All right, we are back. Episode 22. My name is Dr. Deepak Dugar.
And I'm Dr. Jeff Toll.
And today we're talking about some cool stuff. We're going to see... I'm stealing your pun. See into the future.
We are.
Some good stuff. We have David Lazar, a retinal specialist.
And he didn't even make up that, because, for a while, he's a retinal guy. He uses lasers.
Laser.
So I thought when I first met him and he's like, I'm Dr. Lazar, I thought he'd change his name. It's like
to
Dr.
Laser.
Like Dr. Tatoff.
Yeah.
But in fact, Lazar is his real name.
Lazar, also known as Laser for the retinal specialist. Ophthalmology specialist. But he's going to be on and tell us some great stuff about the eye. We're all going to learn a little bit because I don't know anything.
I need to know more.
Yeah, the eye is tough. The eye is a weird place.
Yeah. But
let's delve in. So part of the crazy election stuff that happened, one major thing that happened was decriminalization of a lot of quote unquote formerly illegal drugs.
Yeah, so a lot of states approve marijuana either for medical use or recreational use, depending on the state we're talking about. Mm-hmm. Oregon went a little crazy.
Oregon's decriminalized.
Oregon is a wild place
mushrooms, psychedelics.
I think they also decriminalized or made methamphetamines and some other crazy stuff.
Yeah, I guess depending on the amount you have and if you're using for personal use. But yeah, decriminalized. So magic mushrooms have also, psychedelics, recently the study showed that helps with depression, which makes sense.
Yeah, so
makes a lot of sense.
I think they've been looking at this for various drugs over the last 5 to 10 years more intensely. So including psilocybin, which is magic mushrooms, including what's it called?
All the different psychedelics.
MDMA, which is ecstasy.
Yep.
Including some of the other some weird things like ketamine.
Mm-hmm.
So
ketamine is very popular for depression.
So what these studies are looking at is there's two different ones. Some where you give low doses of these drugs actually to someone while they're in their psychotherapy, and it allows people to kind of open up, get out of their own. Because a lot of times with psychology, we're sort of stuck in our own thinking patterns and the way we're seeing it, and this is allowing people to get out of their own skin and kind of see it from the outside, so to speak. And there's been some success. I actually know of a clinic or a few clinics that do this type of stuff with psilocybin actually in LA, where you can actually do therapy.
And they prescribe it actively while you're sitting there. It's not like they give you a little pill of magic mushrooms to go home and play with.
No, it's not. So I think that's where a little bit of the confusion is it's not that you're just supposed to go do a trip and see what happens.
And just run around the village.
And you have to be selective because if people have some psychotic part of their psychology,
it can make it worse.
If they've had hallucinations in the past, if they've had other either schizophrenia or bipolar, you may not want to jump there. But there is definitely, I think, it's interesting because as the pharmaceutical companies had such a stranglehold on the FDA of what was approved and not. These drugs like oxycodone, which were so damaging.
Yeah, almost worse than a mushroom.
Were prescribed to millions of people.
Yes.
And yet things like marijuana that we know are very safe.
Right.
Were not allowed to be prescribed because there couldn't be a, company that could say this is my drug and
there wasn't enough money behind it, organized money.
Well, I think organized money, but they're also, you couldn't patent it because it's a naturally occurring thing.
Well, the only reason patents are important is because organized money.
Right.
Yeah, because somebody's getting money off of a patent.
Right.
Yeah, and so marijuana is just easily grown, so there's no singular source.
But it behooves...
Just like PRP treatments are impossible to FDA approve because there's no way to patent PRP, really.
Right. I think that the thing is with these drugs like marijuana, the pharmaceutical companies could lobby to the FDA that they wanted their drugs approved. Mm-hmm. And like you said, without a way to patent it, everyone has the same ability to
grow marijuana. Yeah, which is crazy. My spiel on this is that I think that this is like psychedelics, mushrooms, psilocybin, all very potentially powerfully important drugs that could help a lot of people.
Yeah.
Problem is that it's just like alcohol. Like if you've ever had a drink of alcohol when you're in a bad mood, I usually feel better. You usually feel a little better. You get a little lighthearted, start to get a little more jokey. Life gets a little better for at least an hour.
Yeah.
So the problem is that a lot of people become alcoholics, right? And so it's the same kind of concept with these kind of drugs. Same thing with OxyContin and oxycodone. Oxycodone's a great drug for someone who has a little bit of pain, needs a little bit of medication to get through it, and then they're done with it. Right. But the problem is the addiction is so powerfully strong with these medications that the last thing that I would ever want is for us to have a society that's now dependent on psychedelics, because that's way more dangerous than, potentially the depression that they're currently struggling with. So it depends. I think it has to be a safety level.
They have to figure out, I think there's definitely some truth to the fact that they could be super helpful. Mm-hmm. It's just figuring out the right way to do it, how to give it, the dose.
Yeah, like maybe a monthly dose, maybe like a quarterly dose, like in a way to kind of awaken the spirit.
In other cultures, they do have ceremonies where they have locally grown, drugs that people take as an experience. That's in some ways spiritual experience. So I've learned a little bit about, in Brazil, they have ayahuasca where people do a ceremony and it kind of gets you out of your body, and people have these amazing experiences where they can kind of really on a dime change big parts of their life they've been struggling with. And
it awakens like a deeper sense of their mind and thoughtfulness that they were not engaging before.
Exactly.
Right.
To reach it reaches another level that they couldn't get outside of this thought process that was blocking themselves or whatever it was. And they can get to that next level. And that same type of thing around the world, there's other Native American cultures that were using peyote or cactus-based things. I think there's some even weird things where like licking a toad that makes you, I forget what that one is.
Yeah. No, I know exactly
what you're talking about. But they're all similar in the sense that they're a way to get people, it's just like a shock to your senses kind of. It's like restarting the computer, or is an analogy to just like start afresh.
And I think that's exactly the way that if psychedelics were to be used, should be used. They should be used on like a once a quarter or once a month or once a year basis to shock, like reboot the computer basis.
Right.
But I don't think it should be the way that oxycodone or marijuana have kind of pervasively taken over society, because I think could make it less productive. Right. So but very interesting. We'll see what happens.
Yeah.
So tell us, COVID is getting obviously way worse.
So
real wave 2 now. Real wave 2.
Yeah. So unfortunately, I think this is the combination is in the parts of the country that were minimally affected at the beginning or less affected at the beginning, the Midwest.
Yeah.
A lot of those places, thought it was a hoax because they really weren't seeing anyone who had it.
Right.
They got away with not wearing masks because there was no one there who had it. And then culturally, it became this thing where, if you, obviously we've talked about this before, the political sides you take, not wearing a mask. And so now that it has finally reached, rural America, Midwest, the northwestern states, it's exploded. So in the Dakotas and stuff, it's the highest per capita number of cases of anywhere in the country.
Wow.
And again, those are places where people are not wearing masks.
Right.
So it's really going to be bad. I'm really worried about some of the East Coast cities. I think New York, again, I've said this before, may have some insulation from some herd immunity from that first massive wave that they have. But some of the other cities like DC potentially that weren't as affected, but still are dense populations areas, I'm very worried about this winter because we're all used to seeing each other. We've all been having dinner outside, and all of a sudden it's going to be too cold to be outside, but we're all used to seeing each other again.
Right.
And so I think we're smart enough not to open sports and have 30,000 people in a stadium, but even if it's just 10 people by 10 people at each of these dinner parties or family greetings, Thanksgiving. So I really think if you're going to be if you're in your 20s and you're seeing your friends and you're doing stuff and you're about to go home for Thanksgiving, please test yourself for COVID before you go home because you would be fine if you got it and you're just with your friends. You're probably not going to get sick.
Your grandparents.
But your parents, grandparents, it's super important because, with all the travel that happens in the holidays, it's just another opportunity for people to pick up in the airport, on the plane, feel fine the first few days they're home.
Yeah, but be spreading it asymptomatically.
And then be spreading it. So.
Yeah, even when your mom or grandmother tell you, don't worry, just come home, stay with me. You don't need to wear a mask. I'm your mom. Don't listen to your mom. This is the moment where you don't listen to your parents. Do the right thing. Wear the mask. Get yourself tested before and after, and just socially distance. But be there. Be with family. I agree. There's nothing wrong with that. But it's just no one knows the right thing. Like we have in California one of the strictest governors around COVID, right? Governor Newsom, and even he a few days ago was caught, quote unquote, at a restaurant, very famous, really expensive restaurant called French Laundry with 12 people having a whole birthday party. Oh, and, and he's the one touting, do not be in big groups. No, even 10 people's too much. Wow. And yet, he's sitting there at French Laundry, a $500 person meal. So, I'm not saying he shouldn't have done that or should do that. I'm just saying that it's complicated. Even our leaders don't fully know what the right thing or wrong thing is.
It's very tough. I'm worried about the numbers exploding. I'm worried about
another shutdown. I'm worried about
because we're always lagging on the hospitalization side of things about 3 weeks after the numbers spike, and
that's when
we've set the world record for most cases in a day, multiple days in a row now,
which is scary.
So if you project that forward about 3 months, it's going to look terrible, especially as it gets colder. It's just going to be...
Yeah, because now normal flu's starting. And that's what's going to get confusing.
Yeah, and so, the same mask wearing, the same social distancing will help you not get the flu. Everyone should get a flu shot this year. I think part of why we worry about the flu is if someone has viral symptoms and a fever, we won't know, is it flu, is it COVID? And that's why. But this is... scary time coming up here.
Well, COVID's not done. That's the moral of the story. And
it's not.
Please take it seriously.
I think the good news is we did see some really good news on the vaccine front this week too.
That there might be some actual options coming soon.
2 of the vaccines look like they're potentially about 90% effective.
Yeah, Pfizer and Moderna.
There's some still open, real questions about safety when you give it to the whole population, but you can see a path towards at least the highest risk groups getting the vaccine, hopefully pretty soon in the next few months.
They were saying potentially even as early as December.
That would be cool.
We'll see. Yeah, that'd be great. I would recommend taking it, and to be honest, I would probably take it myself even if I had the first round of it. But it would be exciting to see.
We got to see.
So you got to see.
Someone who's going to help us see.
So let's bring in our guest of the day, Dr. David Lazar, ophthalmology, eye surgeon, retinal specialist, who's going to help us see.
Sticking needles in the eyes.
All right. And we are back with our very special guest of the day.
We're going to see things very clearly
today. Things. I like that. That. Very witty. Dr. David Lazar, who's a retinal ophthalmology specialist here in Los Angeles.
Welcome.
You're welcome. In your own private practice?
That's right.
Wonderful. Well, thank you. We're going to learn a lot about the eyes today.
He helps us all see the world clearly, which we all need right now.
That is very important to see the world. My sister's an ophthalmologist too.
Oh, really? Where?
Yeah. So she's in Orlando, but she trained at Bascom Palmer, and she is anterior eye.
Got it.
Whatever that is. I don't know anything about the eye. We're going to learn today.
We all need to learn about the eye.
Yeah. The eyes are tough.
Yeah. I know that when someone is complaining about the eye, if I don't know what it is in the first two minutes, then they need to see the ophthalmologist. Yeah.
Well, it's actually kind of simple. The eye, what I tell my patients is that the eye is really analogous to a camera. So there's a lens and there's film. And the lens is really cataracts, cornea, that's what we were talking about earlier, LASIK. That's all the lens of the eye.
Got it. That's what my sister does.
Right. And then the back part, the film of the eye, the film of the camera is the retina. And it's really like you can think of it like a 2-compartment system. And that's why I specialize in the back part of the eye. And it sounds like you're Sister is the front part of the eye.
So the back part of the eye and the front part of the eye, even though it's one little tiny eyeball, are just totally different components.
Yeah.
So what happens? So light is going in. It
how do we
has
see?
to cross through the lens, I suppose, and then that tries to get it to hit the retina, which is the analyzer. Is that right?
It's really, again, it's just like a lens.
I don't think any of us know how a camera works.
So you're right that light is actually bent twice, essentially. If you want to get more technical, but essentially it's twice.
Yeah.
It's through the first, when it enters the eye, the first part it's bent is the cornea.
Right.
Right? The clear part where you put a contact lens. Right?
Right.
So that's the first part, light is bent. And then the second part is, like you said, the lens. And together, they focus light onto the retina, which is the film of the camera. That signal is sent to the brain, and then the brain says, that's a chair or that's a surfboard.
Right.
That's a beautiful woman or beautiful man. Got it.
Well,
so that's how
no,
you
no.
visually see the world, is through your retina sending messaging to your brain.
That's right.
Got it.
So obviously, there are many reasons why people can have problems with their vision. So what tends to be a retinal issue when people are losing retinal vision?
So that's a good question. There's two from a medical. So you could break that question down into medical causes and surgical causes. So medical causes, the most common, at least in the United States, are diabetic disease and macular degeneration, which is really a disease that affects
Elderly.
elderly people.
What's macular degeneration? Explain that a little bit.
You want to hear the analogy I tell patients?
Yeah.
It's actually pretty good.
Yeah.
Okay. So you can think of your retina like a sidewalk, okay? And let's say this patient X is 80 years old. So I say, think of your retina like a sidewalk. If you had a sidewalk that was 80 years old, what happens to the sidewalk? What happens?
Yeah, it gets cracked.
It gets cracked. Bingo. So those cracks in the sidewalk, that's dry macular degeneration, the dry kind, okay? It's really microscopic cracks in the sidewalk from wear and tear, age-related.
Age-related.
And then what does that do? So when the light hits it, there's no like receptors to sense the light, or how does that?
It's a complicated answer, and I
Okay.
don't want to get too technical.
Okay,
but
fair enough. But basically causes, so and that
Issues.
tends to cause central vision loss, is that right?
Yeah, so the macula is the center part of your vision. It's where
Right.
all the good vision is located.
Right.
But it gets trickier. So the dry kind is the cracks in the sidewalk, and we don't do anything about that. I don't have a drug that acts like pavement to pave
Yeah,
over
there's
the
no
cracks.
medication yet.
No, yet.
Yeah.
But what we care about is, have you ever seen a sidewalk with cracks in it where grass grows through the cracks?
Mhm,
The same thing happens in the eye, except it's not grass, it's blood vessels. And these blood vessels leak and they bleed, and then we call it wet macular degeneration.
Got
And
it.
in this analogy, we have medication that acts like weed killer that causes these blood vessels to regress and the fluid goes away.
And that's like
Got
the anti-VEGF drugs?
Bingo.
Okay, got it. And those are eye drops that people use.
Injections.
Oh, injections. And that's where you come in.
That's right.
Got it. So you actually stick a needle, brace
You
yourself
stick the needle
into the eyeball?
for this?
And then they say thank you at the end.
Oh my
Wow.
God.
How does this
that
not hurt?
Does it hurt?
Yeah, good question.
Do we have nerves in the eyes?
Yeah, on the wall of the eye. Yeah, it doesn't hurt.
Wait, really?
Interesting.
And so you will topically numb the eye,
Mhm.
like eye drops, and then you literally just right there, they're sitting in the clinic and you stick a needle in their eyeball, just like I do for Botox in the
That's what I
face.
do all day.
Wow.
You guys are both, I don't know how people hang out with you guys knowing that you stick needles in people's eyes
Yeah.
and you cut people's noses off.
Well, cutting noses off is awesome. Sticking needles in the eyes is crazy. Yeah, see, it's funny. Like, even though we're three doctors, none of us can understand each other's fields. It's all crazy to us.
Yeah.
That's not.
basically.
I remember in med school when I was studying for my step 1 exam, I literally, it's our biggest board exam that we take. It's the first one, the huge
Yeah.
one for us. And when I was studying for it, the eye section came up. It was so complicated to me. I literally skipped it, didn't study it, and I said, I'll just miss these questions. And I'm so glad I did. I still don't understand the eye. It's so complicated. So complicated.
I think it's just like anything. If you do it all day, every day, even the most complicated subject can become
Yeah, normal.
straightforward. Yeah.
Ophthalmology is very competitive too to get into. Very hard field. How many ophthalmologists are there every year? Do you
There's
remember?
500 residency spots.
500 residency spots. Okay.
Yeah.
So
I mean, this was last time I checked, which
Yeah.
was,
So
These
within-
don't change that
With
often.
an aging population, don't we need more ophthalmologists, what do
Yeah.
you think?
100%.
And it's one of the few things where there is not really like nurse practitioners and PAs that can actually do the work, especially real complicated work like you're doing, right?
But I guess optometrists can do a lot of the diagnosis for you guys. Is that kind of how it is?
Yeah, that's a complicated topic as well. And in different states, there's different privileges that are, delineated between optometrists and ophthalmologists.
So most people don't know the difference.
Yeah.
Do you want to so an optometrist is not a medical doctor.
They go to optometry school.
Right.
They're a doctor of optometry.
Correct.
OD.
Correct.
Got it. And you are an ophthalmologist. You're a medical doctor.
Correct.
Who's a surgical subspecialty.
Correct.
Got it.
That's basically,
And you guys are either best friends or hate each other, depending on the state.
I'll just talk about here, and it's a very good atmosphere
Collegial.
here, very collegial. I work closely with optometrists and ophthalmologists every day, and it's LA. There's something in the ether that just we all get along here.
Yeah, that's so nice.
It's really
to hear.
nice.
Yeah, because I hear a lot of like ophthalmology, optometry drama, and then psychology, psychologist drama. Like, you hear about these specialties.
There's in every specialty. There's that.
Yeah.
type
Do
of
you
thing.
guys have that in internal medicine? Do you have like?
Medicine doesn't have it as much. It's more like specialists that are battling for who's going to do what.
Yeah.
So like in our hospital, for example, vascular surgery and interventional radiology do a lot of the same procedures, and
Right.
we'll argue about who's supposed to do them.
Right.
And then there are some things where a completely different approach, will make. There's no clear evidence as to which is a better way to do it, let's say.
Right.
So even different specialties that don't do it the same, because interventional radiology and vascular surgery essentially do the same procedure.
Right.
They both do an angiogram of the peripheral blood vessels, let's say.
Right.
It's just in your hospital, one may.
Right. And I guess that's the kind of like the thing about medicine is certain procedures are really protected. Like a retina procedure, nobody in the world does except for a retina specialist within ophthalmology.
Right.
Even general ophthalmologists wouldn't mess with the retina, I assume, right?
Yeah.
Yeah.
And so it's really protected versus like Botox. There's like 95 specialties who can do that, So it's like very dependent on how.
But no one can do it as well as you can.
Yeah, and that's also why I do nose jobs. That's specifically why I do nose jobs, because I don't want to compete with the nurses all day. There's some amazing nurse injectors, and it's like you just can't compete. And they also charge half the price of a doctor. How are you going to compete with that? So I stick to nose jobs. You got to be better. And you got to have clientele who appreciate the fine details. It's like eating at Wolfgang Puck versus eating at Wolfgang Puck Express. There's different levels.
I think there's no. My honest take is that I think nurses could be very talented.
Oh, some of them are better.
And
some of them are
they
way
can be.
better. Yeah.
But
it's all about practice.
yeah, basically.
Yeah, it's all about practice. But with your field, like, because obviously the love for the eye is why you do what you do. Why would someone become an optometrist versus an ophthalmologist? Like, what would be the reasoning?
That's a very good question. I think it would be personal. I think it would be, if you didn't want to do surgery on the eye, it's pretty intense, and there could be a lot at stake. And if you just don't want that kind of pressure, perhaps, I don't know though.
How do you deal with that pressure knowing, because, you're knowing if you really screw it up, that person's going to lose vision. Isn't that a lot of pressure?
Totally.
Is it easy to mess up? Is the margin of error really small or
Very
not
small.
really? It is small.
So
Wow.
when you're doing I wish I had a picture, but retina surgery is very analogous to laparoscopic abdominal surgery. There's 3 small incisions on the white part of the eye, and you work through these 3 small incisions. And if my patient who's awake most of the time wiggles their big toe, I can see it under the microscope. I could see the
Eye moving.
Yeah. Well, just the body.
Yeah.
Wow.
It's that level of magnification.
And they're awake usually?
Yeah.
So you don't strap them down?
The ones that misbehave, I do.
All right. So
But even if you put their hands, let's say you do hand restraints because they're kind of loopy,
Right.
they can still you don't strap down their toes.
Right.
So it's-
wow. And
I have much less pressure.
your field.
I think with each interaction, it's different.
It's
Well,
different.
yours is harder because like we've talked about this a lot, me and Jeff, because surgical subspecialty like I do versus general medicine, which you do, yours is all about the diagnosis to get them to a treatment, and mine's all about the treatment, but easy diagnosis.
Right.
So you have a lot of pressure with getting the right diagnosis.
Yeah, but you have I think 2 things. You have a little more time to, hopefully. So, if you get the diagnosis a week later, you're probably okay still.
Yeah.
You can get consultants in to help you.
Right.
It's never like in that. I mean, occasionally in the hospital during a code or someone's oxygen levels drops, and you have got to figure it out really quickly.
Yeah.
But in the most part, we're a little slower.
Yeah, that's a good point.
And I don't have a needle in someone's eyeball.
Yeah. Needle in the eyeball.
So I think a lot of people want to talk about their screen time and how that affects their vision, or if it affects their vision. There's a lot of people trying to sell these blue blocker glasses online this year since the pandemic started. So is that real? What do we need those? Does that protect us?
Yeah. So it's a good question, and I'm going to answer that from my perspective.
Okay.
So if you get 10 different eye doctors in a room,
Sure.
you're going to get 15 different answers on that.
That's why we have you.
Yeah. I can tell you that I haven't read any convincing literature that says that the blue blocking glasses protects the retina in any significant way. That's not to say it doesn't exist, and maybe I haven't come across it or something like that, but I have not seen anything. The biggest issue with screen time, especially during this pandemic, is that people are reading up close and kind of using their near vision a lot, and that could actually tire out the muscle in the eye that helps focus. So if you do it for a long period of time, your eyes can get fatigued.
Yeah.
But there's no like permanent damage that could be done from that.
Got it.
Gotcha.
Yeah.
So what would be the result of that? Like headaches or
Yeah,
just
some people say soreness,
Yeah.
eye strain,
Right.
headaches.
Gotcha.
And the cure for that is just take a break.
Take a break or a very mild pair of reading glasses that help like with the near work, depending on the age of the patient.
And using your phone, is there a certain length you should be using your phone? Like if you're laying in bed, you're having it, 2 inches from your eyes, scrolling on TikTok. Is that not good?
That's not good for other reasons. That's not good for many other reasons. But from an eye standpoint, as long as it's in focus and it doesn't hurt.
Okay, so as long as you're in focus,
Yeah.
then no problems.
Right. So like, do you have any friends who are like super nearsighted? Like they have those thick glasses,
Maybe.
See, in my world, it's very common.
Jeff doesn't hang out with nerds.
Well, they probably have contacts or whatever.
Right. But these people, when they take their glasses off, if they want to see something clear, they're like, it's
Yeah,
close.
super close.
And that's
Got
just because the optics of their eye, that's how it's built.
I have the opposite problem. I can't see far away. I can see up close. I can read just fine. And I never even knew I had a slight vision issue until med school because I can't help but talk and, mess around the whole time. So I had to sit at the very back of the hall not to bother everybody else. And I couldn't see the board. So that was the first time I realized I had
Wow.
some vision issues.
Should everyone get their vision checked on a regular basis? Or if you have no problems, just leave it alone?
There's two schools of thought. If it ain't broke, don't fix it, right? So that goes into if you're not having any problems. But quite honestly, I think everyone should go at
Get
least
their
yearly,
vision checked.
not necessarily to a retina specialist, but
Yeah.
get their eyes checked, make sure they don't need a pair of glasses. And then, there's a lot of things when you look in the back of the eye, you'd be surprised what you find that's asymptomatic. There's freckles, there's coronal nevi, which is essentially a freckle in the back part of the eye that needs to be monitored. And if no one looks,
Right.
you don't know that you don't know that it's there.
And is getting your vision checked at like LensCrafter okay? Or does everyone need to be going to like a specialized doctor for this?
I would refer back to the previous question. If you're not having any problems, you
Yeah.
can get just a basic exam, whatever's easy for you.
And at a place like LensCrafters, that's probably an optometrist who's just checking your regular vision, basically.
Correct, but depending on the lens crafters, they can do eye exams and look in the front of the eye and back of the eye and make sure everything's generally okay.
Gotcha.
Got it. And what about sunglasses and UV protection?
Yeah.
Is that a real thing? Is that necessary?
Yeah, it's a good thing. It's just like think of it like UV protection for your skin. There is the lens that's in your eye has some UV blocking ability too. So you have some
Your
inherent
natural lens.
Yeah, oh yeah. So you have some inherent protection there, but the skin on your eye, you can get cancer there.
So it's a cancer thought is for the skin on the eye. It's not about the eyeball itself, or is it both?
it's kind of both.
What happens to the eyeball? Cancer or no?
So there's a range of things. I actually have these too, and a lot of people who are born and raised in LA have them because of all the sun exposure. You can get growths of skin. The white part of your eye, it can grow and form like a little mound. It's called a pterygium or a pinguecula. Do you guys remember those terms?
Yeah, totally.
It's from chronic sun exposure and so that's like the basic part. And then the more severe part is, squamous cell or.
Yeah, the real stuff. Yeah, crazy.
So here's a question for you guys. So I also know that there's a world where your guys' eye and face doctors collide in like an oculoplastics.
Yeah, trauma, cancers.
Yeah.
Yeah.
And it's kind of like exactly things in the eye socket.
Yeah.
Because that's what I always worry about. Here's a question for you. So when someone's having headaches or sometimes new headaches with maybe an aura, so it kind of sounds like a migraine, how often is that something where they need either imaging of the brain or because I'll have patients who come to me, they're in a stressful time in their life, especially now with COVID.
Right.
And they have a new pattern of headaches, maybe with some flashing lights, maybe not, or feeling like vision changes or heaviness. Like when do all those people need imaging? Do they need a brain MRI? Do they need an eye exam? What do we do for these people?
It's a great question. So there is something called a retinal or ocular migraine, which is a kind of separate entity from a migraine with aura. And the classic description is, 15, 20 minutes, bright flashing lights, usually colored, jagged lines, plus or minus blurry vision. And it's a terrible name, ocular migraine, because it has nothing to do with migraines.
Does an ocular migraine, you see bright flashing lights. Is there also a headache, or there's no headache and it's just the flashing?
Usually there's no headache.
Gotcha.
Usually it's just the visual symptoms.
Okay.
Migraine with aura is kind of a separate thing. And my practice pattern is, if it's classic, 20 minutes, flashing lights, colored lights, jagged lines, all the key buzzwords that I'm looking for, I don't recommend imaging. If it's changed, right? If they say, last year it was 10 minutes long, now it's like 45 minutes long, and instead of seeing jagged lines, I see, a blurring of my vision that doesn't go away. If there's some sort of meaningful change, then I would recommend imaging after an exam, of course.
Right.
Retinal exam.
Right. Because it's confusing because there's a lot of reasons why someone can have flashing. There's also like floaters, which people describe, where all of a sudden they're lifting up a suitcase and then they start noticing some blurring or some weird darkness or colors. So what does that mean?
The lifting the briefcase one, or the
all of the above?
Yeah.
So how do we know basically what I'm saying is, my patients will come to me first line,
right,
typically, and say, what is this? What's going on? And usually, as I said, I was talking before we were online saying how internists know, 70% of most specialties, but about 10% of ophthalmology. So if there's basic things on the outer side, like conjunctivitis, I can see what it is. But if there's any visual changes, immediately, obviously, sending it up to the ophthalmologist.
Got it. So flashing lights and floaters is something I deal with a lot. And the reason for that is it can be a precursor sign of a retinal detachment. At a certain age, your eye is filled with gel. Your eye is hollow like a basketball, and it's filled with gel called the vitreous. And at a certain age, the vitreous separates from the retina. That happens to everybody. And just with an unfortunate few, when the vitreous separates from the retina, it pulls on the retina and pulls it off. And that's called a retinal detachment. It's something I fix surgically, and we have really nice outcomes with it. But the idea is that if you get it addressed early, right? So if you go get an exam at the earliest signs of these flashing lights and floaters, the outcomes are better. You catch it earlier, you treat it earlier, and just it means better outcomes.
Gotcha. How do you shoot lasers at it, or you actually stitch it? What do you do?
So, if it's just a tear in the retina, so again, let's think of like wallpaper now. If the retina is the wallpaper, if there's just a tear in the wallpaper, I can laser it in the office. But if there's fluid under the retina, if there's a tear now and fluid has gotten under that retina, you follow me? Mm-hmm. That's something that needs to be fixed surgically.
Weird.
What type of sutures do you guys use? 13-0?
Great question. No, 13. Does that exist?
Yeah, I don't know. How small do you go?
Like 8-0.
8-0, okay.
But retina. So we get made fun of because 8-0 is like
that huge?
Standard. But for the eye, they're using like 10-0. For cornea, your sister probably uses like 10-0.
Stuff. Right. Yeah, 8-0 seems kind of big.
If only I knew what stitches were.
Yeah. They go numbers. Like 1-0 is like a huge stitch. 8-0 and 10-0 are super tiny stitches. Usually you need a microscope to even see like, the work for sure. Yeah, in residency, we used to do a lot of enucleations, like the big eye surgeries, because we would do skull-based tumors. And so, like a big ethmoid or sphenoid sinus tumor that's invading into the optic nerve, something crazy like that. And we used to do these big enucleations and skull-based surgeries. And I remember one time we were doing one, and you have to like tie up the optic nerve with a suture, and then you have to cut it, and which is scary because that's like you cut the nerve, like, oh my God, this patient's never going to see the rest of their lives. And so the attending's like, go ahead and cut it. So we cut it, and then as soon as I do, he starts showing, oh my God, why would you have cut that nerve? And it's just him joking around and jerking on us, but it was so scary.
He definitely
to me.
panicked.
Oh my God, definitely. You think your life's over, you just killed someone's eye for the rest of their lives. But have you ever been involved in those kind of like hardcore cases? You have to remove an eye?
In residency. So I trained in New Orleans. And there's a lot of trauma there.
A lot of trauma, yeah.
In the county hospital, you can only imagine. So there's a lot of that.
Yeah.
But after after you do retina, I've tried to stay away from that.
Stay away from the trauma. Yeah.
Yeah.
So retina, you're doing more of like super subspecialty. And right now in private practice, are you solo or are you with a group?
Solo. So I started my career after training with a group, and then I started my own practice about just under 2 years ago now.
Wow. And how does one start a solo retinal practice? I imagine there's a ton of equipment. You have to buy a ton of equipment?
Ton of equipment.
Okay, got it.
It's a big investment of time, energy, financial.
Yeah.
But I've never done anything more rewarding.
Wow.
I couldn't imagine not working for myself and having my own practice and doing things, practicing medicine the way I think it should be done. It's just very rewarding. For all the stress, the reward is there.
Yeah. We all
I'm sure
feel the
yeah.
same way.
Right.
Yeah, because all of us have our own practices. And
Yeah.
there's something rewarding about being a business owner and knowing that you're contributing to society, not just in terms of your service, but also in terms of your staff and they're dependent on you and you're
Love my
taking care of
staff.
them. Yeah, you love your
Love
staff.
not having a boss.
Yeah, I love not having a boss.
My boss is a gem because it's me.
Yeah. Actually, I have a boss. It's my wife.
That's true. That's true.
You have a boss now.
That's true.
He has a puppy boss.
That's true. He is a terror.
He's got a 8-week-old, 10-week-old
I
puppy?
think now he's 9 weeks.
9-week-old
kind of dog?
puppy.
He's a half Cavalier, half Poodle.
Okay.
Oh my God, so
And
cute.
he is a maniac and likes to bite my toes 100% of the time.
Because he knows you have weird feet.
He likes my weird feet. I think it looks like
He listened to the
it
episodes.
looks like a dog chew toy. So anyway, but he'll play catch. I figured out now if I play catch with him and run around with him, he'll sleep immediately.
Yeah, you got to tire him out.
After 30 minutes of running around, he'll sleep.
You got to tire
So,
him out. Yeah, smart.
Figuring it out. It's difficult because I live it. Another problem is I live in a high rise, so it's hard to. They can't hold it that long. So after he eats, I want to get him down.
Yeah.
But it's just
Yeah.
it's a struggle.
But it's a boss. So
a
aside from
boss.
being a private practice,
How
you still
do you
have a
get
boss.
enough time? Don't you spend a lot of time? I mean, you're busy.
Yeah,
Is it that a lot?
my girlfriend takes care of the dog most of the day.
Got it.
Yeah, so I get some
Yeah,
relief.
Dogs need a lot of love. Do you have a dog?
Yeah. No, I'm that's next on the to-do list.
Yeah. Don't rush. But it's amazing. It's really rewarding.
Yeah.
I have a 3-year-old dog.
I couldn't otherwise. No, for sure not. I'm
Right.
not home nearly enough to. That's why I never had one before. That's why I don't know what I'm doing.
Right. Well,
I think that's for years, especially for anyone listening to the show who's a resident or training, thinking about starting your own practice. It is many years of a lot more work for sure when you are getting things going because you need to be there. It's all you, and I think there's pros and cons, and I think like we all said, the upside if it works out is great. But it's a long road to get there. So.
Oh, absolutely. And everyone's journey is different. I have a lot of friends in private practice who after 2 or 3 years took off, their practices are booming and they're just killing it. And some people it takes 10 years, and it's just whether it's going to be 2 or 3 years or 5 years or 7 years or 10 years till you get booming. It's just part of the journey. The good thing is that this is a 30 to 40 year career. So no matter what, you're going to have a lot of decades of success and happy practice, happy patients. But it takes time. And I think that's the one thing that people give up on. Because I do have a couple of friends who went private. And then after a couple of years of the struggle, they just, it just wasn't working out. And then they quit and jump ship and take a job, which is fine. Nothing wrong with it. But I think that you got to have that long-term commitment when you're opening up a practice and going on your own with whatever you're doing in life.
What just out of curiosity, what city and specialty were they in?
All my buddies are plastic surgeons. So plastic surgery and LA.
Very competitive.
LA and New York, and 2 dermatology friends in LA and 1 in New York as well. So dermatology and plastics.
Very competitive.
Very competitive.
It tends to either be massive success or very difficult.
Yeah, and the difficulty can last forever sometimes. And you can just have a very slow or mediocre practice for a long time until something lucky kind of strikes. So I think, all of us, knock on wood, have done well and we're very blessed to have such great practices. But I do sympathize with people who are starting out their practice because it's tough. I mean, all of us had a tough time the first few years and it's just part of the journey. It makes you appreciate it so much more.
Now we get to celebrate Diwali.
Now we celebrate Diwali. Yeah, happy Diwali.
Did I say it right?
You said it right. Yeah, Diwali.
So can you tell us what it means? Because I think it's a great. I was in India last year during it.
During Diwali?
Yeah.
Wow, what a treat.
I was in Delhi with my friend Levi that you met. On the previous episodes,
2 episodes ago. Yeah.
And we had a great time. There was fireworks. lights.
Yeah.
So what does it mean? What does the holiday mean?
Diwali's it's our New Year. It's the biggest Indian
it's New
holiday.
Year.
Yeah, so it just happened this past Saturday, and it's the kind of the light over darkness, good over evil. It's the mythologically the gods killed the biggest demon of the time, and it was a mythological success to good over evil triumph is what
that
the whole
sounds
story
like
is.
exactly what we need right now.
It's exactly what we need. More light, less darkness.
He's controlling the light in your eyeball.
Yeah.
And we're controlling
and without
the light.
you, we can't see the light in our eyeballs.
You had kind of like a Hanukkah vibe.
Yeah,
it sounds
it's kind of like a Hanukkah vibe.
Yeah.
It's as important as Hanukkah is for you guys. It's as important as Christians think about Christmas. That's Diwali for Indians. So Diwali is a big deal.
So what do you do to celebrate typically?
So
Food?
you do
guys have
you do
great
prayers.
Sure.
Great food, of course. Great food, prayers. Spend time with family and friends, and you do all like little traditions, lighting the candles. Like we have our version of candles, just like you guys do on Hanukkah.
Yeah.
So very similar stuff. I feel like all religions were kind of very similar, especially Judaism and Hinduism. Very similar.
Are they?
Very. There's a lot of traditions that are kind of overlapping.
You guys have more gods.
We do, but you know what's funny? Everyone thinks that we actually Hinduism technically is one god in many forms.
Really?
Mm-hmm. It's not really that we have millions of gods necessarily. It's millions of forms of the same gods.
Really?
Yeah, it's not really a polytheistic religion the way everyone thinks.
I thought there was let me see, Shiva. And what's the guy? I like the elephant guy with all the arms.
Oh yeah, Ganesh.
Ganesh.
He's the god of prosperity and happiness. And I mean,
we need a little more Ganesh in our life.
Yeah, there's lots of difference, but it's just kind of like reading the Bible. You know, there's a million characters in the Bible.
Right.
So it's the same concept. There's a million characters in Hinduism, but
Gotcha.
It really comes down to the construct of, do you believe in God?
Right.
It's the singular belief in the Almighty, in God. And do you believe in that or not?
Gotcha.
Which is always interesting, because I think nowadays, as educated and advanced as we are, a lot of people have this view that, listen, you can't be educated and knowledgeable and still believe in God. You know, I'm not saying I believe, that's not what I'm saying. I'm saying that's what some of my really educated and smart friends say to me. And I think it's interesting, it's interesting.
There's lessons. There's good lessons.
Yeah. I will say when you're probably working in the back of the eye and something's going wrong, you probably believe in God in that moment.
Oh yeah, definitely. I'll believe in anything to get me out of there.
Yeah. What is a typical retina case like? Like, are you literally...
How long are you in there?
Yeah. What's that like?
The longest case that I do is about hour and a half, 2 hours.
Perfect. Yeah, same as me.
Yeah. Anything longer than that, and when I was doing my surgical rotations, I wasn't interested in doing Whipples or these crazy.
Yeah.
Some of the head and neck surgeries are
very long,
really long.
Yeah, that's why I don't do them.
Yeah. So an hour and a half to 2 hours, and what I like about retina is that it's microsurgery. So there's usually no stitches, usually. So it's pretty elegant. I mean, you use these ports, small incisions, you do your thing, you get out. The next day, the eye looks pretty good. So it's nice. It's not like some of the abdominal surgery that I'm sure we all remember.
Is it like by hand, or is there a robotic element to it yet?
So there are some people who are developing...
Like a mini Da Vinci type of thing?
Something like that. But it's not mainstream, and it's all done by hand right now.
Gotcha.
And I think for the foreseeable future.
Gotcha.
What makes people's eyes different colors?
Their iris.
Iris.
Yes.
What is that? Where is that?
That's in the front part of the eye.
Front part of the eye.
Does it affect your vision in any way?
Not usually.
What's the best eye color?
Whatever eye color I have.
What color?
I was going to say mine.
Yeah. And when people are blind, is it usually born blind? Is it because of something with the optic nerve or something in the eyeball? Or is it both? Could it be
There
either?
could be so many reasons.
Okay. So it could be so many
There
reasons.
can be so many reasons.
And if someone's born blind, do they have eye health to maintain or no?
It's a really good question.
Like, could they have macular degeneration?
Are there people that are born blind and they never see? Or what?
Yeah.
What are the typical reasons they're blind?
Well, there's a lot of inherited retinal diseases or optic nerve diseases, or even just malformations, congenital malformations of the eye.
Right.
Those can all result in...
childhood blindness.
Yeah.
There were a lot of in the old days, there were a lot of, I would assume there were infectious reasons or otherwise for...
Right. So if you get corneal scarring,
right?
If the front part of your eye, the cornea scars over and becomes opaque, so light can't enter it.
In the third world, are there things like that? Like
Definitely.
Infections? I'm trying to think of what they would be. The only infections I ever see on the eye really are, I guess, viral things and occasionally bacterial, but not that often.
Yeah, but because it's West LA.
Yeah.
But there's a lot of stuff.
I saw some shingles on the eye the other week. That was a very weird case where this guy had a scab pop up just actually on his forehead, no, not even close to his eye, right next to his hairline. And he said he was itching and burning, didn't believe me that it was shingles, didn't want to take the Valtrex. And then 2 days later, when it was really burning, then he did want to take the Valtrex, but he saw his ophthalmologist and he had some, I guess, signs of inflammation on the eye. So he was taking steroid drops on the eye with the Valtrex oral.
Sounds good. Sounds like a good plan.
Are there no Valtrex drops?
There is, but the pills are just easier and more tolerated. Yeah.
Gotcha.
It's a miracle drug.
But going back to the blindness, you're at a point. What were you going to say?
Well, I was going to say that what's interesting is not an interesting piggyback off what you were saying was that there's this thing called amblyopia. Have you ever heard of this?
No.
So you can be born with a totally normal eye. Let's say you need glasses. Maybe just you don't see clearly, right? And if that glasses prescription isn't addressed by the age of 9, your visual cortex doesn't develop properly. So your brain doesn't know how to see properly. Does that make sense?
Yeah.
So you can have a totally normal eye,
right,
structurally,
right,
but you just can never see past, whatever your eye is.
I think this is something
it never gets addressed.
I think this is something so interesting about how, in general, how the way we process all information at the end of the day is actually our brain.
Yes,
so when
everything.
you see something, yes, the light goes in your eye and it's a lens and the retina absorbs the light, but it's actually the processor is back in the occipital lobe of the brain. The brain, it's actually the brain seeing.
So
exactly.
So then to piggyback,
the eye's
what
just
you were
the camera. The eye's just the camera.
Yes,
just the camera. You still have to plug it into a computer.
Yes, which is the brain. And to piggyback on that, so all kids should get their eye checked.
100%.
Yeah, so that's a normal thing. Hearing and vision checks for kids.
100%.
Standard. That's always been done. Always will be done.
Well, it should be done.
Yeah,
and especially before the age of 9, because that's when the occipital cortex is done, the visual process.
So if you have an 8-year-old at home right now and has vision checks, you better run. Yes.
I think by then the kid would tell you they can't see very well.
How'd they know?
Kids are very,
Well, there's, I don't know, trouble reading, I don't know, maybe not. I don't have kids, so what do I know?
You got a puppy.
Sometimes you have to tease it out of them.
Yeah.
They won't offer the information.
Do you see children also?
I don't. But it was just an interesting part of going through training. I had to do a pediatric rotation, which was several months long. And it's just interesting, like you were saying, the connection that people just think, if you have a normal eye, you'll be able to see fine. It's just so much more complicated.
This applies to a lot of other things, a lot of things that I talk to my patients about too, like chronic pain and stuff like that, where, someone will have, let's say, back pain, and they're always focused on the back. But at the end of the day, again, the brain is what's controlling their pain signals. And so there's a lot of patients who have these things like fibromyalgia where they're in pain all the time. And we look at where the pain is coming from. And again, it looks fine. So they're saying, well, my legs hurt, this hurts, that hurts, but you do x-rays, you examine the joint, everything looks fine. I can't explain why the knee hurts other than it hurts. And so there is something in the processor that's probably what's broken. And in 2020, we don't have a good solution for that disease,
not yet.
For example.
What's the advances coming for 2050 onwards of the eye? Like
when are we going to be like plugged into like a neuralink for the eye that gives us hawk-like vision?
Right, because like we're doing brain implants now. We're doing cochlear implants for the ear. We're doing auditory brainstem implants if the auditory nerve is messed up. So what's like the visionary future?
So that a version of what you're talking about is already here, where you can have a retinal implant and then you have plugs to the brain, but it's not fine-tuned.
Right.
Future.
Will it be there?
Oh yeah, definitely. And I think what's a very interesting thing, which isn't retina related, but it's ophthalmology related, is augmented reality and vision. So like a contact lens or glasses where you go around, you see things and your vision is incorporated with augmented reality, right?
So it's meaning like putting a Snapchat filter on top of
that exists.
Something like that.
That exists already, right? There's companies that are doing this right now.
Didn't Google come out with glasses that does that?
Yeah, that didn't do well though. But there's currently a contact lens company that's doing tremendously
Contacts
well.
with it?
Yeah, contacts with augmented
Wow.
reality. Yeah.
Wow.
Yeah. It's doing tremendously
People
well.
are going to be so useless, more so than they already are. We are. We're like, there's no point of us once we have augmented this and that.
Well, you still have to click the Uber button.
I guess so.
I guess maybe
Yeah.
you won't have to once it's
Well,
augmented.
once the cell phone is fully merged inside of us,
yeah.
so like you just think and then the contact lens puts the article you're trying to read or whatever on there.
Absolutely. Would you get a Neuralink?
I'm scared of the Neuralink.
I'd get a Neuralink.
This
Would
is
you?
the Elon Musk thing?
Yeah. Where they've kind of fine-tuned it now to the point where it's like they're almost ready to start testing on humans. And it's exciting. I would totally do one.
Well, you need brain help. Mine seems to be working pretty well.
You have a perfect brain. Perfect brain with perfect hair.
Thank you. Well, it's covering the brain. That's protection.
How many days pre or post shower are you?
No, I shower. Okay. Listen, I shower daily. You just don't wash your hair daily. Ask all these dermatology friends that
I will.
that you have
I will.
how often to wash their hair.
Jeff's convinced me that not shampooing his hair, you do it about twice a week. Once a week.
Once to twice a week.
Once,
depending
twice a
on
week
what's
is the
going on.
secret to his insane hair health.
I mean, you can't argue with the results.
Can't argue with the results.
I mean, it's an
I
N
know.
of one, but
But it's like when they use Fabio to sell hair cream commercials. It's like, come on.
Yeah.
Fabio never used those.
Yes, he did. And look how well his hair works. He didn't shower. It's obvious.
When we see Jeff Tool hair cream,
Let's
we're
have
going to know.
Fabio on because I'm going to ask him how often he shampoos his hair. It's probably once to twice a week.
That's a great question. It's
It's because the chemicals. There's a lot of chemicals.
A lot of chemicals in the shampoo.
well, you can get chemical free. Can't you get like the
I don't
Tom's
know,
of
but
Maine or?
but then a lot of times when you shampoo it, it gets very like flat again.
Mhm.
And so then people put product in to groom it, which a lot of times has alcohol in it. And so it leads to this cycle, in my opinion,
Yeah.
of I have no basis for it other than, again, my own.
Your
But-
own hair. Yeah.
But I think I do think using alcohol a lot.
Do you have thicker hair than your brother?
He won't like this answer, but yes. Yeah.
Nice.
Yeah.
All
But
right.
he for many years was using like an alcohol-based product to
Gel.
do his hair, like a
Yeah,
gel.
got it.
For like 10 years.
Yeah.
So
I've
who knows?
never used product in my hair.
Yeah.
Ever. Yeah, that's one thing I agree
I
with
put
you
a
on.
tiniest bit of like just wax pomade.
Uh-huh.
It's literally like wax.
Just to kind of tame it.
Tiny bit, like the first day after the shampoo.
Yeah. Just to
And,
tame it.
just a little bit.
Yeah. Well, what's funny is you never had long hair before, right?
No, I've had it on and off.
On and off. Okay.
Yeah.
Okay. On and off.
Yeah,
I like this.
I
How-
grew it very long once in college during a soccer season to try to put my hair up and stuff.
Your
you know,
Brazilian
to play
face.
better.
Yeah.
You could play better with hair up. It's obvious.
Yeah.
And then last year was really long,
Longer than now.
way longer.
Wow.
Yeah.
Wow.
It was like 2 hands in the ponytail
Oh,
at
wow.
one point last year.
That's amazing. I love that. Yeah, we talk about the most random things on the show, as you
No,
can
it's
tell.
great. It's great. Cover everything.
Yeah, but no, it's great. I
Uh-huh.
mean, the vision future we're excited about, and we're happy to have great doctors like you who are helping and taking care of your patients so well. And if people want to find you, where can they find you, doctor?
Probably on my website, lazarretina.com.
Lazar, Lazar, retina.com.
Yeah.
Okay, great. And
Or
you-
just an easy Google search.
David Lazar.
That's right.
Wonderful. Well, thank you so much
Thanks
for
for
joining
being
us
here.
today.
Thank you.
Great talk
Thanks
about
for
the
having me.
eyes, and
Yeah.
learned a lot today. This is awesome.
See you in the future.
See you. I like that. I like the puns. So
There
witty.
you go.
All right. And that was a great episode. Dr. Lazar, fantastic information today.
That was helpful.
That was helpful. Yeah. We jumped around a lot, but it was nice.
I'm not good at asking questions.
No, it was great. It was great. I think we extracted a lot of weird and great information out of him because the eye's confusing. I mean,
It's
I'm still
very
kind of
weird.
confused.
I still don't get it.
Yeah. But that's a good episode. I really enjoyed it.
So speaking of the eyes,
Yeah.
I think a lot of people want to know if you have any recommendations on during this time where we're not getting enough sleep and we're stressed. How do we make the eyes look more young and full and
Yeah. I would say
sexy?
Yeah, beauty tip of the day. So I would say one little secret that everyone should be doing is a low dose micronized retinol cream. You can buy these online. There's lots of different types. One that I like is an Ayurvedic 90210 cream, but it is a small micronized retinol. And micronized retinol is really important because micronized retinols can go into the pores versus non-micronized retinols, which sit on the outside of the skin, and use a small amount, maybe less than a pea-size amount, 2 or 3 nights a week max. So don't do this daily.
Where do you put this?
And so what you'll do is you'll dot it all over your face, and then you'll rub it in, and then whatever residual is left, you'll rub it just underneath the under eyes and upper eyelids, just to get your eyelid health, to maintain a little bit of that structural integrity by using low-dose retinol, but just the tiniest amount around the eyelids, 2 to 3 nights a week max. And if it's too dry for your skin, if your skin's getting really dry, then cut it down to once a week, or even, once every 2 weeks if your skin's really sensitive. But using low-dose retinol around the eyelids, super, super impactful on keeping them young and healthy and a little bit more vibrant.
I like to look young.
Yeah, it's important to match the young hair that you have.
There you go.
It's very important.
There you go.
But thank you guys so much for listening. Episode 22. David Lazar, thank you for coming on, and stay tuned. We have great guests coming up in the next few episodes.